Welcome back. Make sure to like, share, and subscribe to Decode Healthcare with Harshal. It's wild to think that a single misplaced two-digit modifier can instantly trigger a massive claim denial. Today, we're jumping right into part 3 of our medical coding explainer, and we are putting the spotlight directly on surgical modifiers. If you've ever found yourself second-guessing which specific code belongs in the operating room, well, you're in the absolute right place. Let's get right into it. So, are surgical modifiers causing denials for your practice? Because let's be real, incorrect modifier usage isn't just a simple typo. It's a massive revenue drain. It's a leading cause of claim rejections, and honestly, it's an open invitation to auditors looking for compliance issues. To fix this, we're using a fast-paced versus showdown format today. We're going to tackle the high-stakes modifiers that most commonly trigger those dreaded denials and leave your hard-earned money on the table. Let's kick off our very first showdown, Modifier 50 versus Modifier 51. Now, these two get mixed up all the time, but they serve completely different clinical purposes. Modifier 50 is strictly for bilateral procedures. Think of a bilateral knee replacement where the exact same procedure is performed on both sides of the body. Modifier 51, on the other hand, is for multiple procedures. Picture a scenario where a surgeon is repairing a hernia, but they're also removing an appendix during that exact same operative session. The billing strategy here is where things get super interesting. For Modifiers 51, you've got a golden rule. Always sequence the procedure with the highest relative value unit, meaning the most complex, highest paying procedure as your primary code, completely modifier-free. But for Modifier 50, you really have to watch out. You've got to double-check your payer-specific rules. Why? Because while some payers demand Modifier 50 for bilateral work, others actually prefer you to bill using the RT and LT anatomical modifiers instead. Okay, moving on to our second showdown. What exactly happens when a surgery just doesn't go as planned? Are you electively reducing a service, or are you abruptly discontinuing it due to serious danger? This brings us to the absolutely crucial difference between Modifier 52 and Modifier 53. Mixing these two up can trigger an immediate audit, so we really need to break them down clearly. So Modifier 52. This is for reduced services. The key takeaway here is that this reduction is entirely at the physician's discretion. Imagine a planned colonoscopy, where the physician can only advance the scope partially, simply due to the patient's unique anatomy. The doctor makes the call to stop there. It's an elective reduction based on anatomical reality, not some sudden, life-threatening complication. Now contrast that with Modifier 53, which is for a discontinued procedure. This perfectly illustrates the difference. 53 is strictly used when there's a severe, unforeseen threat to the patient's well-being, specifically after anesthesia has been administered or the procedure has officially started. For instance, if a patient suddenly develops severe hypotension during an operation and the surgical team has to abort immediately to save their life, that is when you use 53. And because of the sheer severity involved, Modifier 53 carries a notoriously high audit risk. Payers are going to heavily scrutinize this to ensure that discontinuation was an absolute medical necessity. To protect your practice, you absolutely need bulletproof clinical documentation. You have to detail the exact patient safety risk or the extenuating circumstances that literally force the termination of that procedure. Moving away from interrupted surgeries for a second, let's look at what happens when a successful surgery is actually divided among different physicians. We literally split the global surgical package into 3 chronological steps to reflect who did what. Pre-operative management only, that's billed with Modifier 56. The actual surgical care only, that gets Modifier 54. And the post-operative management only receives Modifier 55. Splitting the global package does carry a medium audit risk. Payers want to be absolutely sure services aren't being duplicated across different providers, so you must have crystal clear coordination. You need to document the formal transfer of care arrangements right in the medical record and communicate directly with the operating surgeon. If the surgeon only does the operation and a local doctor handles the 90-day recovery, both have to bill their specific components flawlessly. Otherwise, you're just asking for duplicate billing denials. Next up is the often misunderstood Modifier 57, Decision for Surgery. You append this to an evaluation and management, or E&M service, when that exact visit acts as the catalyst, the initial decision to actually perform a major surgery. But here is the vital distinction. And honestly, this is where so many practices face really costly denials. You must only use Modifier 57 for major surgeries. We're talking surgeries that carry a 90-day global period. If your E&M visit results in the decision for a minor procedure, meaning a 0 to 10-day global period, you have to use Modifier 25 instead.
Getting this time frame wrong is an instant red flag for payers. No doubt about it.
Quick recap time. Keep these core definitions and use cases for modifiers 50 through 57 mapped out in your mind, or better yet, printed at your desk. It's going to ensure your daily coding stays perfectly clean and compliant. Getting these basics right is literally the absolute foundation of healthy revenue cycle management. And that wraps up part 3 of our explainer. But before you go, ask yourself, is your practice currently leaving money on the table? Or worse, are you inviting an audit simply because of a misunderstood modifier? Take a look at your recent claims and find out. Thank you so much for joining me today. Be sure to hit that subscribe button because you will not want to miss part 4. We're going to do a high-risk deep dive into the Office of Inspector General's most heavily audited code, which is Modifier 59, and exactly how to safely use the XEFPSU modifiers instead. See you next time.